Okay, that's what happens when you're 50 years old and you're doing something via Zoom. I think I've got it now. You guys can hear me, right?
Yep.
Yeah, we can hear you fine.
All right, so let's get started. Um, do you see my screen?
Yep.
Okay, so this first case, and Max, I'm glad you're on. I'm showing a case that we saw when you were here. It's not this one. So this is an 87-year-old guy who had gross hematuria, went to the urologist, and was found to have a well-defined hyperemic patch of mucosa involving the left lateral wall that was seen on cystoscopy. And so they did a biopsy. Okay, so this is the biopsy, and tiny little biopsy, but it looks very cellular. But you know, the problem with some of these urothelial lesions is that they're eosinophilic and the background is collagenous and eosinophilic, so it can be hard to kind of see the true nature of the lesion and how extensive it is on H&E. But what you do see is it looks like there are these small nests. Some of them are a little smaller than others, but a lot of them are kind of medium-sized nests. They're right underneath the predominantly denuded epithelium. But again, they look pretty bland. You know, maybe they're a little atypical, but the nuclei for the most part are round. They have little nucleoli, but like if, you know, this is part of the net, these are pretty bland. You know, maybe they're a little bigger than the background stromal cells. You don't see a lot of hyperchromasia. You don't see a lot of mitotic figures, apoptosis. So I think that this is kind of, to me, it was a difficult case also because once I saw this, I'm like, you know, is this cancer or are these von Brunn's nests? You know, what is this? What's going on? But yet I wouldn't think that you would have kind of nests like this going down next to these little twigs of smooth muscle. This is not muscularis propria. This is muscularis mucosae when you have the small little fascicles of smooth muscle. So I went to the clinical history and I saw that this wasn't even a mass, really. This was just a little hyperemic area. When you see like hyperemia and cystoscopies, if it's going to be anything, it's going to be CIS. So I thought that this kind of bothered me. And then the other thing that I thought about that you need to think about is a paraganglioma, because paragangliomas would be bland. They'd have rounded nuclei, abundant cytoplasm, lower NC ratio. They'd be present in these nests that are about the size. And if it's one of those things I focus on, if you don't think about, you're not going to make the diagnosis. So I started with a GATA3. So here's the GATA3. So the point of me showing you this immunostain first is if your differential is a urothelial carcinoma versus a paraganglioma, GATA3 does not help you. They're both positive. But what this does help me is that this no longer really looks like the architecture of a paraganglioma. You've got a lot of looks like single infiltrating cells. And if this is a urothelial carcinoma, this is like a small nested variant. You know, you have large nested, small nested. There's lots of different types of variants. But when in small nested or nested variant in general, most of the time they're intermixed with a usual type of urothelial carcinoma. And when you do see them, when you look deeper, one of the keys is that they no longer have that nested growth pattern. They can get a little more like, you know, infiltrative, single cells, trabeculae, and that's kind of what we're seeing here. So even though the GATA3 in and of itself doesn't tell me that this is urothelial because it still could be paraganglioma, the architecture is kind of beyond paraganglioma, and it's certainly beyond something that's benign. So I had done a synaptophysin just, you know, kind of for fun. Given that differential, there is some positivity, but it's not the tumor cells. It's like probably some little nerve twigs or something in here. given the architecture, that linear staining, but the tumor is actually pretty much negative. And then, of course, CK7 is positive. Most of these are CK7, CK20 double positive. It's one of the few carcinomas that's consistently CK7 and CK20 positive. So this is CK7. Again, look at the architecture. This kind of takes it out of anything benign. This is not some benign mimicker. These aren't von Brunn's nests. The irregularity is too much. They're too deep. That's the other thing about nested type invasive urothelial carcinoma. This is CK20, just showing you this tumor was 7 and 20 positive. You know, the other thing you can think of with this, a weird growth pattern in the bladder. I've shown you several mets to the bladder. You should always think about that as well. But, you know, when something kind of looks urothelial, although a little bit blander, then I think you should really focus on a urothelial primary. But, you know, again, think about other things in your differential. I think for me, paraganglioma was the biggest one on the H&E. So now this was kind of bland, but how do you grade these? So grading is kind of a controversial topic in bladder cancer. There's really no formal grading system. Most of these are almost by definition high grade. So what you really should do in these cases is probably just call them high grade. If WHO is not really helpful in guiding you about this. They do say that if you have a subtype, which a nested variant would be considered a subtype, then by definition it's high grade. And even though these are bland, these stage for stage are just as bad as any other invasive urothelial carcinoma of the usual type, because they tend to be very deeply invasive. So just the fact that it's kind of on the bland side shouldn't automatically, you know, knee-jerk say it's low grade. I don't think I've ever called an invasive urothelial carcinoma low grade, honestly. I usually call them high grade. They used to be considered high grade by definition, and now some people have said, oh, well, actually, they're probably, some of them are low grade, but we don't even know if that really means anything. Now, let me show you this case. This is a TURB. This is harder. So this is kind of more of the size that you would think of with a von Brunn's nest. Now look at, this is the overlying urothelium. A lot of times with these urothelial carcinomas that are nested variant, the overlying urothelium does not show CIS, so that's not going to help you. But these are pretty bland, and it's right, like that could easily be a von Brunn's nest here, that here. But then if you take a step back, this is, I think, a little too architecturally complex to be von Brunn's nests at this point. Okay, come on, camera. All right. There's too much interconnecting nests. There's too much variability in the nests. And then, you know, these should have bland nuclei. So if it's truly a benign von Brunn's nest, these aren't really completely bland. There's big nuclei. There's some irregularity. That's pretty irregular. That's pretty irregular. That's really irregular. So this could be hard if this was all you had. I think this could be really hard, especially, you know, this area. A lot of times von Brunn's nests have like central luminal openings, but then you've got a big vessel here and it's surrounding the vessel. Now this is made a lot here by, if I move over to the next piece, here's a more conventional invasive carcinoma. This one is in the detrusor muscle, the muscularis propria, which, you know, ups the stage. So, but these can be really hard when you just have a little bit of it. And then, now this is another one, another case of bladder biopsy. So again, very nested, kind of relatively uniform, medium size. Are these von Brunn's nests? No, I don't think so. There's too many of them. They're too deep. There's also a very prominent vascular pattern associated with whatever this is. These are all vessels. This is a nest. This is a nest. Vessel, vessel, vessel. This is a very vascular looking tumor. This isn't what you typically see in urothelial carcinoma. And again, this is too extensive to be von Brunn's nests. And then when you look at the nuclei, this is very stippled, rounded, round to oval, regular nuclear membranes, low NC ratio. This is a paraganglioma. So paraganglioma of the GU tract is rare, but when it is in the GU tract, the vast majority, like 80%, are in the bladder. When you see these in kids, they're almost always germline mutations. In adults, it's about 50-50. If a clinician called you and asked you, well, is this benign or malignant? The answer is that you don't know until it metastasizes, because there really is no good consistent grading system for paragangliomas, pheochromocytomas. There have been a bunch suggested in the past. None of them really work that consistently and are that specific or sensitive. So you basically have to wait for a met. And then even with that, you need to be careful. I've made this mistake in the past where I knew someone had a paraganglioma and then I saw another one in another location. I assumed it was a met, and it was a paraganglioma, but in retrospect, after I thought about it like a few months later, I thought, you know what, I bet that was a new primary in someone with a germline mutation, because they get multiple of them. So unless there's multiple in the lung or multiple in the liver and the person has a known big paraganglioma, be careful about calling it a met. But this is a paraganglioma. I think these can look very much like a nested urothelial carcinoma. The stroma, I think, is a little more vascular than what you would see with most urothelial carcinomas. And then I want to show you this case is another large kind of nested urothelial carcinoma that has a lot of kind of microcystic, and microcystic is another kind of variant of urothelial carcinoma. This one's very microcystic and also nested. Again, it has kind of an irregular growth pattern that's inconsistent with anything that's benign in the sense that it's going deep. But I will show you this area. And I think that if you have just a little bit of this at the surface, I think something else should be in your differential. Look at this. Very bland nuclei, kind of almost hobnailing in some areas. Low NC ratio. This one's, this is pretty superficial. Now, I think the key here is that this looks like a small cell CIS. So if you see something that looks like CIS and then anything below it, you should be thinking it's probably a malignant infiltrating lesion. But I think this just in and of itself looks a lot like a nephrogenic adenoma. So let me show you one of the nephrogenic adenomas I had. This is exactly what I just showed you. This is a nephrogenic adenoma. But you can see how this can, they often talk about nephrogenic adenomas mimicking prostate cancer. And I think that's more of a immunohistochemical mimic than an actual histologic mimic. I guess it depends, because a lot of nephrogenic adenomas are around the urethra. And so if you're going to send a man, if you see prostate cancer involving the bladder, you usually see it kind of coming through the urethra or the bladder base. So I think knowing that someone has prostate cancer, maybe was had a Foley catheter, maybe had stones because of obstruction, those are all setups for a nephrogenic adenoma. So that clinical scenario could really make you think about prostate cancer, but it's also a good setup for a nephrogenic adenoma. And you see something like this is kind of like a cribriform prostate cancer, but it also can look just like a microcystic and nested urothelial carcinoma. Now, the key with these, I think the thing that I've seen in my practice with other colleagues showing me cases like this is that we're so used to seeing papillary urothelial neoplasia, and the differential is often pun lump, low-grade papillary carcinoma, that they see papillae and they think, oh, I guess this is a pun lump. Would you call this a pun lump? It's kind of weird. There's only one cell lining. And so that's the thing, is that nephrogenic adenomas can be very papillary. And the key is that they have a single layer lining. No urothelial proliferation should ever look like this. And then the other thing, remember, these come from renal tubules. So they're going to stain for PAX8. And they can often have this kind of colloid-like material like you see with the thyroidization of pyelonephritis with renal tubules. This is kind of the classic hobnail morphology. You know, it's they often talk about the basement membranes of nephrogenic adenomas being very prominent. I think that that's overstated in the literature. I feel like I see a lot of them, and I don't often appreciate that. What I more often appreciate is this hobnail appearance with the kind of flattened lining of the epithelium. The fact that they're very superficial, the vast majority are under a centimeter in size, and that they can be they can have a lot of different morphologies with that kind of hobnailing, and then a more like tubular, you know, when you get this more tubular look, then you really think about like a 3+3 prostate cancer, especially because these can have distinct nucleoli, just like a prostate cancer. And, you know, you get that the Ranke crystals, which you could maybe, if you're not paying attention, you just have a little bit of this, you could think maybe that pink is a Ranke crystal, not really a secretion. So anyway, it's a differential to keep in mind. This can look like a lot of different things, and I think in this one example, you see the reasons why. Let's see, what else did I pull for this case? Oh yeah. So this is another mimic of a malignancy in the bladder. These are really, really rare. You don't see many of them. When you do see them, they're mostly in men, like 6-to-1 ratio. These are usually small. They're often kind of, I think, bladder neck area. This is an inverted papilloma. So the key with an inverted papilloma is kind of a low power diagnosis. This very complex branching, anastomosing nests, but they are very uniform. Like a lot of papillary urothelial carcinomas can have a inverted growth pattern, but with those you should see some trabeculae that are smaller, others that are really, really wide, much more atypia. With an inverted papilloma, you should think about it at low power because it's relatively uniform looking, and you see peripheral palisading. Peripheral palisading is a very common appearance. And then the other thing is the center parts are often streaming with squamous differentiation, or even like cystic change. This one has some cystic change. It can have glandular differentiation. Again, it's that peripheral palisading, the central streaming, almost spindled looking, is very good for an inverted papilloma. Although some of them can have somewhat of an exophytic look, when you see the overlying urothelium, it's typically very flattened. I think I have one more just to show you that kind of uniform appearance. This was in a TERP for prostatic hypertrophy. And so here you see that same kind of eosinophilic debris secretions. You often see that in inverted papillomas. So inverted urothelial papilloma. Again, notice the peripheral palisading, almost like a basal cell carcinoma, but without the stromal retraction. And again, that central kind of streaming. These are very bland. You should not see anything that you would consider like pleomorphism. You typically don't see mitotic activity. But it's that inverted growth pattern, the peripheral palisading, the central streaming, the uniformity. These are usually small. They're usually well defined. So inverted papilloma. All right. Any questions? Okay, let's move on to case 2. So case 2, I took pictures in a very particular way for this case. So this is a 44-year-old woman who had a history of abnormal uterine bleeding requiring blood transfusion. That's how bad it was. They did an ultrasound of the pelvis at the time that she was in the ER, I think, and it showed a heterogeneous myometrium with thickened junctional zone. And so this was after the blood transfusion, after like, I think a couple weeks when she presented to the office, they did an endometrial biopsy. So what I did, and I did this to talk about something I don't think I've talked about with you guys before, is when you're in practice, there are going to be times when you're walking by a colleague's office or you go into a colleague's office and they say, hey, let me show you something. Let me show you, I want to, get your opinion on this area of the slide. And they say, do you think that this is pseudo-decidualized here? And so they'll, point out something like, hey, look at this, this looks like, a big fragment of endometrium. It looks like it's kind of, looks like there's more eosinophilic cytoplasm. The glands are kind of inactive looking. Here's some areas I thought about chronic endometritis, but I couldn't find plasma cells. Do you think this is pseudo-decidualized? And you look at this one area and say, yeah, I think it is. And, it looks like it probably has some pseudo-decidual progestin-like effect. And then, they sign out the case, they put your name on it. And then what they didn't do really is show you the rest of the slide, which has all this other tissue on it. That's happened to me several times in practice, only early on, because then I kind of got wise to it and said, oh, let me take that case. I'm having a hard time seeing it under your scope. Let me take the case and look at it myself, because there was one case I can remember where a pathologist kind of curbside me and I looked, double scoped with him while he was driving, and he showed me one little area in an ovarian cyst that he told me. And it just had a very simple, clear lining that was very bland. And he said, I'm not really worried about this. Are you worried about this? I think it's just like, bland lining. I'm not really seeing anything worse than that. I'm like, yeah, it doesn't look very atypical to me. There isn't much of a proliferation. It's a single layer. So he signed it out as like a clear cell cystadenoma of the ovary. I didn't know he was going to do that. Like, you hardly ever see that. And he put my name on it that I agreed. And then 6 months later, the woman presented with mets to her liver. And when I looked at the actual case, when I pulled the case, I'm like, I don't remember seeing this case. Like, every other slide had like classic clear cell carcinoma on it. And I was like, ugh, that motherfucker just like took me down with him. And so thankfully that was like 17 years ago, never got sued about it. The reality of the story is that even if he had diagnosed it as a clear cell carcinoma, probably she would have had mets 6 months later anyway, or she may have even had them at the time. So there was no negligence in the sense that nothing bad happened because of it. It probably happened anyway. But that was lucky, and I certainly learned my lesson after that, which was like the second or third time that had happened to me where someone had showed me something. So this case, if you're a pathologist and say you think this is all like, oh, this is just all sampling of the endocervix while they were going into the endometrium, you discounted it, then you would just focus on the endometrium, focusing on the endometrium. But the point of this case is that there is a shitload of squamous epithelium here. This is way more than you would see going through the cervix, sampling through the endocervix. Even when you see an ECC, you don't see this much squamous epithelium. This is a woman that is known to have uterine bleeding, and she's got some epithelial proliferation, and it's all mature squamous. So then the question is, well, where is it coming from? Is it an endocervical lesion? Is this an endometrial lesion? And so then you really have to go closer and look at where's the squamous epithelium. And I'll tell you, to me, this is involving the endometrium. This is a kind of a bland looking endometrial gland. I do think there's progestin effect. So that would actually make me more suspicious, because women that have endometrial cancer and EIN, when they're treated with progestins, can often have prominent squamous metaplasia in the atypical epithelial proliferation. And so that's actually should not dissuade you. And look at that. So here's a bunch of squamous epithelium, and then another like atrophic, inactive looking endometrial gland. Now, if you're going to call this atypical or hyperplasia or cancer, you have to go based on the actual glandular epithelium. So these cases, you have to kind of move around and look very closely. And there were only really rare areas where I could find glands. And I know these are endometrial glands because these are inactive or atrophic endometrial glands. This is like classic EIN in the sense that this is completely cytologically different than the background. And it's architecturally atypical looking to me. especially in the setting of all this squamous metaplasia. And so I was really worried about this being a preneoplastic or possibly an endometrioid adenocarcinoma that I'm just not seeing a lot of it of. But, you know, I really took my time with this case. I wanted to find an area that's like over a millimeter. That's kind of the guidelines for EIN. This area is also looking a little more like the other gland I just showed you. I don't see any normal endometrium in the background, but this is very complex looking. It looks like there's infolding. Again, it's associated with a lot of squamous metaplasia. So there wasn't really much I could find in this case to definitively call this cancer, definitively say it was EIN, but I really felt like this was an endometrial or endometrioid atypical hyperplasia or endometrial atypical hyperplasia, endometrioid intraepithelial neoplasia. Again, here, just looking at this compared to that, you can see the difference. This compared to that, you see the difference. So that's what you should be thinking about. And so I signed this out kind of descriptively as endometrial tissue with extensive squamous metaplasia, focal atypical glandular proliferation, and a background of progestin-like effect with focal breakdown, negative for malignancy. So then I went on, which I tend to do, and I talked about that I favored that this was partially treated endometrial atypical hyperplasia / EIN, which is the WHO terminology, with extensive squamous metaplasia. I talked about there's literature saying that a lot of times when you get progestin therapy in that setting, you have extensive squamous metaplasia, which is what I thought was going on. And then, you know, anytime you have a case like this, you got to talk to the clinician. So I called the OBGYN and told her about it. And then I saw a couple weeks later a hysterectomy on this patient. I was like, oh shit, like I hope I was right. So because I thought that this was atypical hyperplasia, I submitted the entire endometrium because I thought it was going to be hard to find, honestly. Because a lot of times these are treated, after they're treated, they're gone. So here's kind of that more bland, inactive looking endometrium. And then it starts to merge something that's much more atypical. You see all this squamous metaplasia. This is getting very complex. Squamous metaplasia is completely taking over the lumen of these glands. And here again, you've got some atypical glands that when you see them in comparison to what is, you know, the background benign, which is what you really want to see, this is clearly EIN at this point. So then the question is, well, is it enough for calling it cancer? For that, you really need to see back-to-back glands. I didn't really see back-to-back glands, but this is definitely EIN with a lot of squamous metaplasia. Again, that squamous metaplasia can really can convolute the picture in the sense that it completely takes away from the fact that there's an underlying glandular proliferation. And you're not supposed to count the squamous stuff as far as it being solid in respect to grading. And, you know, grading now is binary system. They recommend that you 1 and 2, FIGO 1 and 2 are now called low grade. Grade 3 is high grade. So here is another area, the same hysterectomy, where you don't have any of that squamous metaplasia. And this is clearly EIN. Look at that. That's pretty great, I think, where this is really what you'd like to see. You don't often see it, where you see a juxtaposition and you know that what you're dealing with is atypical. Because a lot of the atypia in EIN or atypical hyperplasia is kind of bland in the sense that the nuclei are rounded, they're a little more open chromatin, but they're not like pleomorphic atypia. So it's kind of almost like low-grade DCIS versus UDH. It's kind of a, sometimes, unless you're really used to it, it's a hard distinction to make. So yeah, I was relieved with that case. Now, just to show you, this is a case I just had the other day, and I wasn't going to show it to you, but then I thought, you know, this is a good example. This is very similar looking. And this is kind of a, you know, people call this different: papillary syncytial metaplasia, eosinophilic syncytial metaplasia. But this is that same mimic of the squamous metaplasia that you often see focally associated with breakdown. And there is quite a bit of breakdown here. And what you see that's kind of has that appearance is at the surface, which is kind of a less worrisome finding, and there's not much of it. I think the volume in the case that I showed you was so overwhelming that it should make you suspicious. Just this kind of appearance, though, if you just, like, again, if someone just showed you that one focus, I don't know, is that a metaplasia in a atypical endometrial proliferation, or is that a metaplasia in the setting of breakdown or menstrual endometrium? Well, I don't know until you kind of back up and look at the whole picture, because one high power field can look identical. This one was just very focal. The rest of it was just kind of benign endometrium. And then, oh yeah, okay, so now I want to shift. I was talking about squamous metaplasia, so let's shift a bit. So this is a case where I think it's enough to call it low grade or FIGO grade 1 endometrioid adenocarcinoma. You've got rounded nuclei, they're back-to-back glands, it's kind of anastomosing, but then you get these areas that are a little more solid, and this doesn't look like the typical squamous metaplasia that we saw in the other case. This is a little more immature looking, and you get areas where there's so much of it that it's very solid looking, kind of spindled looking. So this brings up a few things in the differential. So one thing is that someone could look at this and say, well, this is an endometrioid adenocarcinoma and this area is more solid, so perhaps this is dedifferentiated adenocarcinoma. For dedifferentiated, it should be much more atypical than this. This is not. When I go on high power, this is much more bland, oval, kind of spindled. But you see that kind of distinction in dedifferentiated. The other thing would be a grade 3 adenocarcinoma, but you usually don't have a sharp transition from grade 1 to, grade 3. It usually is, everything else kind of looks a little more solid. You don't just have sheets of what look like grade 1 and then grade 3. Usually that's dedifferentiated, which is worse. So you want to definitely be able to tell those apart. The other thing you could think of is, because this is kind of spindle, this thinking, is this a carcinosarcoma? And this is not a carcinosarcoma. Again, in carcinosarcoma, the glandular proliferation is usually very atypical, very malignant. It's most often like a high-grade endometrioid or like a serous carcinoma or a clear cell carcinoma. You usually don't have grade 1 endometrioid adenocarcinoma in a carcinosarcoma. And then the sarcoma is usually very high grade. So what this is this, I thought this was squamous morular metaplasia, or just morular metaplasia. And that is something that you commonly see, or not that common, but you can see morules in both benign and malignant proliferations, and they can mimic a solid proliferation. So this to me is morular metaplasia. And a lot of people think of it as squamous, and they do describe it as being squamous in the literature, but it actually doesn't stain like the typical squamous epithelium. So this is P40. Here's that, squamous, so to speak, morular metaplasia. It's dead negative. It's known to be negative in morular metaplasia. Let's see. Here's another
Did you do
area.
a smooth muscle marker on it?
Did I?
Yeah.
No, I didn't think it was smooth muscle. To me, it looked like morules. And so here's CDX2. And this is the interesting thing about morular metaplasia. Everywhere, when you get these morules, that's why I've stopped saying squamous morular metaplasia. It's just morular metaplasia, because they're CDX2 positive. Just like you see in cribriform morular carcinoma of the thyroid. They used to call it papillary carcinoma, cribriform morular variant. The last WHO, they took that out. But these are CDX2 positive. If this was like mature squamous metaplasia, CDX2 would be negative. These are also CD10 positive. And then they're beta-catenin positive. Here's beta-catenin. So beta-catenin also stains the background glandular stuff. And then here are those morules. They're beta-catenin positive. So you do not consider that as part of the grading. So this would still be a low grade. And then ER. So here's ER. Now, if this was grade 3 endometrioid adenocarcinoma, this solid stuff should be positive, but in morular metaplasia, it's usually negative. And so that would be the other helpful thing. I think, squamous metaplasia would be something reasonable. I think it should be a little more fascicular. A lot of this is very oval. You can definitely get epithelioid smooth muscle, but then it tends to be kind of nested, kind of clustered. So, but this is a classic look for like morular metaplasia. Now, the place you normally that or more often see that is in the setting of this polyp. And this is a case that I had several years ago. And this was actually, did not have a polypoid appearance grossly. These are more often in women that are in their late 30s. They're often LUS, so lower uterine segment. You have kind of a complex looking glandular background, not that atypical in the sense the nuclei are still kind of elongated. And then you have a bunch of these morules that are involving the epithelium. And then now when you look at the middle, if you think, is this infiltrating adenocarcinoma? It's not in a desmoplastic stroma. This is smooth muscle. So this is an atypical polypoid adenomyoma. Now, the tricky thing about these is these can have associated EIN and endometrioid adenocarcinoma. I think that would be hard to tell because they're already kind of compact looking and they mimic the irregular growth pattern of an invasive endometrioid adenocarcinoma. So I think to make that diagnosis, you'd really want to see a focal area that really stands out from the rest. And I don't think you really have that here. I think the key is to focus on the stroma in between is smooth muscle. And almost all these always have a lot of morular metaplasia areas. I mean, everywhere you look, there's little morules. So that's a atypical polypoid adenomyoma. And then we just had one here not that long ago. And my colleague had this, and he said when he grossed it, it didn't really look like a polyp. These are usually under 2 centimeters. This almost looked like a fibroid or a leiomyoma. And then again, it's kind of complex looking, but then when you look at it, there's a lot of morules. So you see this morule, and then you pay attention to the intervening stroma, and it's smooth muscle. Again, another morule. It's usually not hard to find them. You find them kind of all over. And so he actually did the stains on this one, like I did on that endometrioid adenocarcinoma, and here's CDX2 again. So again, they stand out, these morules. It really brings it out. And again, these would be P40, P63 negative. And then one other thing I want to show you with respect to CD10, I didn't mention CD10. These are CD10 positive also, the squamous morules. That really is strong and highlighted. Again, if it was squamous metaplasia, like we saw in the first case, this would not be positive for CD10. And then here's P16. So P16 is interesting in that it shows these morules, but in the setting of an atypical polypoid myoma, this smooth muscle stroma is P16 positive. So you don't really look at the stroma, but you can see that the stroma in between is P16 positive. That's specific to an atypical polypoid adenomyoma. The smooth muscle in normal endometrium is negative. You see some positive cells scattered in there, but the actual smooth muscle is negative. And then you go back to the APA, and it's positive. So that's one way to tell you're in the setting of an APA and not an infiltrating adenocarcinoma into the myometrium. All right, let's see what else I have for this case. Okay, so the point of the endometrium, one of the points of the endometrium, is that you can both underdiagnose and overdiagnose. It's one of the kind of few organ systems that as pathologists, I think you have an equal chance of underdiagnosing something as you do with overdiagnosing something. The squamous morules, you interpret that as carcinosarcoma or high grade or grade 3 or whatever. Straight to jail. Well, maybe not quite. It's funny. I had I'm going to go off on a tangent now. Liz, you shouldn't have done that. So there was Sharon Hershowitz was a really good South African cytopathologist who I worked with as a postsophomore fellow at UCLA. And she used to always like show difficult cases to her colleagues, and then she'd say, okay, well, I guess I'm going to put your name on this, so we'll go to jail together. We'll be cellmates. We're going to go to jail together. I'm like, yeah, it doesn't work that way. They're going to take away your money, which is probably worse than going to jail. You're not going to go to jail. So yeah, this is a case where this is an endometrial biopsy. These are almost always older women. The big thing that they mimic is something that women get in the endocervix when they're on oral contraceptives or reproductive age in general. And this looks a lot like microglandular hyperplasia. But old women do not get microglandular hyperplasia. And when young women get it, you can get it as a polyp. This is too much tissue to call this microglandular hyperplasia, way too much. So this is actually a microglandular hyperplasia-like endometrioid adenocarcinoma. Here you kind of get the sense of the cribriform nature. These are in older women. These often have like a mucinous metaplasia, which can look like endocervix. They don't have the subnuclear vacuoles. They're more likely having squamous metaplasia that's not underneath. The point is that if you see this much tissue in an older woman from an endometrium, this isn't that they sampled the endocervix and she has microglandular hyperplasia. This is almost certainly a microglandular hyperplasia-like endometrioid adenocarcinoma. This one is very difficult in the sense that there isn't like normal, usual type endometrioid adenocarcinoma anywhere. Maybe you could start to say this is getting a little more endometrioid looking as opposed to this, but this is cancer. And this is something very, very easy to overlook, especially when there's just a little bit of it. Another one that is easy to overdiagnose, kind of like this morular metaplasia. This is another low-grade endometrioid adenocarcinoma, and it has this area in it. This is completely spindle. This is more like kind of smooth muscle looking, but then it gets to this kind of corded looking area, and this is often called carcinosarcoma because it has that kind of myxoid chondroid like sarcoma look. But again, carcinosarcoma, you would not see a background that looks like grade 1 endometrioid adenocarcinoma. In fact, adenosarcomas, this is another tangent, adenosarcomas of the GYN tract can have the epithelium of an adenosarcoma can become malignant. So then you've got an endometrioid adenocarcinoma and a sarcoma. And you think, okay, well, you call that carcinosarcoma. It's no longer adenosarcoma. No, you call it grade 1 or a low-grade endometrioid adenocarcinoma arising in an adenosarcoma because they're so different. Carcinosarcomas are so bad that they're considered different. This is the hyalinizing and sex cord-like appearance that you can sometimes get in these low-grade endometrioid adenocarcinomas that can mimic either solid area or a sarcoma. So it's hyalinizing and sex cord-like elements. And this does not change the grade. You don't include this in the grading. You don't call this solid. One other subtype that was described at MGH before I got there, like the year before, so they always showed us a lot of these, is another endometrioid adenocarcinoma that's often misdiagnosed as a serous carcinoma. And that's because it has these very prominent papillae. But the difference between this and serous carcinoma is that the papillae are made up of cells that are very, very bland. Low NC ratio. In a serous carcinoma, there would be very little cytoplasm here. They'd be very abnormal and atypical. You'd see a lot of mitotic figures. And so this is called an endometrioid adenocarcinoma, all non-villous papillae. Because a lot of endometrioid carcinomas can have like a villoglandular look. This is not villoglandular. This is like micropapillary looking, but they're called small non-villous papillae. And the tricky thing about these is, serous carcinomas are more often in much older women, often the setting of atrophy, whereas endometrioid carcinomas are in older women, but not as old, like 50, 60. These tend to occur in the middle of those two. So they're not quite as old as a serous carcinoma, but they're older than most endometrioid adenocarcinomas. And then one other endometrial adenocarcinoma that can, the same tumor can both cause you to under and overdiagnose it, is another endometrial adenocarcinoma. This is desmoplastic stroma. This is not APA. This is not smooth muscle. This is desmoplastic stroma, which you don't see that commonly because a lot of these endometrial carcinomas are pretty superficial. But what happens is sometimes you can have what's called a MELF pattern, the microcystic, elongated, and fragmented. And that can be very hard to see. And so you understage it. So like if you were measuring it, you may just go to here and measure it. But in reality, there's tumor there. And it stands out because of the inflammation. And that's actually invasive tumor. So that's how you can understage it, by not seeing how deep it is. Now you can also overstage it because you see this. What does that look like? It looks like a lymphovascular space. It's not. That's the cystic spaces look like they're lymphovascular spaces, and they're not. The glands are actually very attenuated, the cytoplasm. This is not lymphovascular invasion. And you know, if you have now in the new FIGO staging system, if you have 5 or more areas of lymphovascular invasion, it upstages them from otherwise low-grade tumors if they're not very infiltrated. Look at that. That really looks like lymphovascular invasion. So you can do D240, you know, other lymphatic markers to try and show you, but these are not lymphovascular spaces. These are just infiltrating carcinomas that, you know, have completely attenuated cytoplasm that looks like they're falling apart. All right. Case 3. Okay, so Max, this is the case we had. Then now you have follow-up. We both have follow-up. This is a 76-year-old man who presented for a screening colonoscopy. And the colonoscopy, according to the internal medicine guy who did it, showed features of colitis from the rectum to 30 cm with shallow aphthous ulcers. And so he did several biopsies along the way. This was like from the rectum. And one of the ways you can kind of tell rectum is if you see a lot of mucophages, that's a good way to tell that you're probably distal, maybe in the rectum. But what you have is that what looks like a very regularly arranged colonic crypt architecture. There is not a lot of shortening. There's not a lot of basal lymphoplasmacytosis. There isn't a lot of branching of the crypts. They go right to the musculus mucosae. But what you do see a lot of are a lot of neutrophils. There are way, way too many neutrophils here to be just like focal active colitis. This is a lot. So usually when you have a lot of neutrophils, it's probably like an IBD, early IBD maybe. But even early IBD should have some architectural distortion. Now, since we're in the left side, if you see Paneth cells, that's a really good indication that you're dealing with chronicity. In the right side, it's not helpful because you can have Paneth cells that go all the way. But when you see all these neutrophils, I was taught at one of these CMEs, I'm pretty sure it was Rhonda Yantis, who actually trained at Mass General and then did her GI fellowship at the BI with Antonioli and Goldman, who are excellent. I think they're both retired now. I did a rotation with them while I was at Mass General because they were such good GI pathologists. But Rhonda Yantis, I remember saying at a CME that when you see a lot of neutrophils, you really need to think about an infectious etiology. This was another biopsy that was done on the same patient. And this was the other thing. This starts to look ischemic. When you get these withered looking crypts, this isn't chronicity necessarily. This is more of an ischemic look. So if you have especially ischemia looking appearance with a lot of neutrophils, that is highly suggestive of an infectious etiology, especially something like C. diff or Campylobacter. A lot of times C. diff, because that's more likely, that's more likely to cause like an ischemic kind of related injury. So again, no chronicity, but withered looking crypts, lots of neutrophils. So then, Max and I were looking at this, and I told him, I think this is probably infectious. I told him my little pearl I just told you guys. So I said, well, now this was a screening colonoscopy, so that's kind of weird. They didn't give us any of that history. I think they said question colitis, but I knew it was a screening colonoscopy. So then I looked at this guy's history. So we looked at it, and it described, this colitis from rectum to 30 cm, and also looked like there was mild possible colitis in the right side in the cecum. So he did a bunch of biopsies, a weight pathology, that was it. So I looked at his history. Turns out he had an epidural abscess before this, and he had been treated with like major antibiotics, had a PICC line in. And so now you've got someone who's been on major antibiotics, something that looks ischemic and infectious at the same time. So I called the clinician. I said, I think this is probably C. diff. And I reported it like that. And so I said it's active colitis without associated chronicity. I talked about, everything I described, the ischemic-like changes, but there's no hyalinization. We'll get into that. And so I said, it's most often seen in the setting of infectious colitis, including C. diff. But I said, you can't say with 100% certainty. So there's other things that can cause that. Medications like cytotoxic drugs, some NSAIDs can do this. It would have to be pretty bad. And I told them about it. So then the biopsy was done on the 19th. So then he ordered all these different markers because I told him I thought it was infectious, and it turned out he was C. diff positive. So for the toxin B. So this is an example of a very early C. diff. And that's what you see is you often just see, like, you don't see pseudomembranes. You just see evidence of like mild ischemia and a lot of acute inflammation. Now, this is the typical pseudomembranous colitis. So this was a C. diff case. And you see that volcanic eruption with the pseudomembranes. That's something that's typical of C. diff. But you can see it in any cause of pseudomembranous colitis, which is, again, drugs, IBD, cocaine, especially in Coos Bay, and other infections, enterohemorrhagic E. coli, Shigella, Salmonella, like a lot of different infections can do this. Is not specific. The one thing I do want to show you, just to have you take a look at this, is that sometimes with pseudomembranous colitis, in particular C. diff, these look like signet ring cells. So if you get a little biopsy and you see disrupted signet ring cells, do not assume that it's neoplastic, because that is not an infrequent GI form of kind of ischemic breakdown. You see that in the gallbladder too. If you really look for this in a lot of these C. diff pseudomembranous colitis cases, you're going to see it. This is a really extensive case of it. And so this would send you to jail, Liz. If you call this signet ring cell carcinoma and the person has pseudomembranous colitis, that's pretty bad. Not going to send you to jail, but that's a bad mistake, but an easy one to make, surprisingly. This is a case of another patient that came in with diarrhea. This looks architecturally normal, but then you've got a lot of neutrophils and kind of maybe a little withered looking crypt here, but very neutrophil predominant, kind of patchy. So this was a case that I had signed out as, this is an active colitis, and I favor that it's infectious. This was a case from the state that shall not be named. And I followed up, and this person ended up having Campylobacter. Their culture was positive for Campylobacter. Now, nowadays, you can do PCR and do a bunch of different, look for Campylobacter, Shigella, Salmonella, E. coli, Vibrio, Clostridium. But they did a culture. When you culture Campylobacter, jejuni, it's usually grows at like 42 degrees. So a lot of stool cultures will be cultured, some of them with that media at higher temperatures, specifically looking for Campylobacter. Campylobacter is like the second most common cause of infectious colitis after norovirus. It's usually a self-limited colitis, so we don't see this very often. But Campylobacter can like Salmonella, Shigella can go on for a while. So sometimes you'll see it, but usually they know that it's a self-limited colitis and they just treat them kind of symptomatically with hydrating them. But again, you see a lot of neutrophils and something that you don't see a background that looks like a chronic colitis. You should think about infectious causes. This is, okay. So now that looks chronic. So you see the glands are shortened. This is left side, very irregular. And then you see Panna cells. So this is a chronic colitis, but then there's also ulcer. So it's an active chronic colitis. This was taken out. This is someone who had ulcerative colitis, had been on medication, but was not really responding. And so in that setting, you really need to think about CMV. And this patient had a CMV colitis superimposed on their IBD. More often seen in ulcerative colitis than Crohn's. These can sometimes be hard to find, but you usually see them on H&E. Now, the thing that I will caution you about is when you have some of these deep ulcers, something that can really look like CMV, but it's not, are ganglion cells. Because they have that same kind of large nuclei, big nuclei, almost looks like Cowdery type A inclusion with a lot of cytoplasm. Don't call that CMV, obviously. Oh, see there too. That could, some people could think that's CMV. You know, you don't need to do an immunostain unless you're not sure. I usually feel like, I usually do it just in case, but I usually feel like it's really easy to see them on H&E. They're usually in the vessels. That's kind of the hint. They have this kind of basophilic look with prominent eosinophilic granules. You can see this is in the vessel. And that's why CMV also causes an ischemic kind of look, because it kind of compresses the vessels. And so it would produce what would be essentially an ischemia. So, you know, these are kind of fun cases to screen and look for. But yeah, you can get, usually when you get a CMV immunostain, it highlights way more than you think there are. But you don't need it if you're sure. And you don't have to screen some of these cases unless someone is really immunocompromised. Then sometimes I will do it because it'll highlight things that don't look anything like inclusions. Now this is what true mesenteric ischemia looks like. And notice how less cellular and inflamed it is. There's still inflammatory cells. It's the lamina propria of the colon. You're going to see inflammatory cells, but it's much more high, very withered crypts. And then if you start seeing fibrin thrombi, that does not mean that it's DIC. Fibrin thrombi in the setting of ischemic colitis does not really mean anything. It's not a sensitive or specific thing. You can see it in both mesenteric occlusive atherosclerotic disease, as well as, you know, DIC, you know, et cetera. But again, very withered looking at the surface, very hyalinized looking. This is kind of the typical ischemic colitis. You see it in the watershed area, so like rectosigmoid. You'll see it in the splenic flexure. If you have something that looks like ischemic colitis on the right side of the colon, then you really think about more ischemic infections like E. coli, especially goes to the right side of the colon a lot. And then, how is this? Oh, yeah. So then here's another cause of an ischemic looking colitis. This one was removed here at this hospital a couple of years ago. And it was just perforated, ischemic, necrotic, gangrenous looking, a lot of abscess. And then I saw these. So the differential for this is K-exalate and sevelamer. And that's what you usually see in patients with chronic renal disease. So that's what this is actually sevelamer. So both of them had this fish scale look. Sevelamer has more of a pink look with yellow on the outside. K-exalate, which is a potassium binder. This is a phosphorus binder. Sevelamer has, or K-exalate is more purple. And then what you're supposed to do is AFB. This had a lot of it. And a lot of times these patients are on both because their renal failure have high AFB, it has a magenta look on AFB if it's sevelamer, whereas KX-late turns black.
Sorry,
So anyway.
I think we lost the image.
Oh, you did?
It stopped sharing for some reason. We saw the sevelamer, and then it just cut out for no reason I can tell.
Oh, that's weird. Can you see it now? The screen?
I've got cell sense, no image on the cell sense.
Really?
Is it just me?
No, I'm seeing that too.
Let me see.
Okay, we're in.
You see it?
Yeah.
Yeah.
Okay. Well, I didn't do anything that time. So here's the AFB. And again, it's like a magenta color on AFB. If it's sevelamer, if it's KX-late, it's black. All right. Well, I'll show you the last case kind of quickly. So the last case is a 16-year-old boy who had an enlarging mass on his left hand palm that was slightly tender. So the point of this is when you hear that clinical history, the two things you should think about are a fibroma of tendon sheath and epithelioid sarcoma. They don't look alike, but that's the demographic that gets a hand mass. So this one is very hypocellular. It has these clefts, very pink. And this one is an example of a fibroma of tendon sheath. They also have these kind of slit-like vascular spaces, very bland nuclei usually, but they can be kind of stellate. You don't see very epithelioid cells. You don't see mitotic activity. There's no necrosis typically. But again, very lobulated. A lot of these tendon sheath lesions are very lobulated, and they have a lot of clefts. Almost like a phylloides tumor, the breast biopsy. Here's another one. Same thing. This was a different case. Has that same low power look. It's like an instant low power, usually 20 to 50-year-old, more often men. You see these clefts, slit-like vascular spaces, hypocellular. Now, if you want to do a stain, the thing that would be in the differential in some of these, here's another one. Again, you see those cleft-like spaces, slit-like vascular spaces. Some of these can be a little myoid looking. So it can make you think about maybe a smooth muscle tumor. That would be weird in the hand. You can certainly get it. And you do SMA, it's going to be SMA positive. These fibroma tendon sheaths are SMA positive, but they're negative for Desmond and other smooth muscle markers. So these are benign. They can recur. The most common tumor of the hand is this. So this is a localized giant cell tumor of tendon sheath. They usually have giant cells. They're osteoclast giant cells, but they may not have many. The mostly of what you have are these kind of histiocyte-like cells, and then kind of ganglion-looking histiocytic mononuclear cells. Even though it's called a giant cell tumor tendon sheath, most of the cells are mononuclear. And then you often also see cholesterol clefts, or you can see cholesterol clefts. You can see foamy macrophages, hemosiderin. A lot of times the foamy macrophages are kind of at the periphery, like this one is. Again, this is more like Teuton giant cell here, but usually have osteoclast-like giant cells. The reason I'm showing you an example of this case is because this is an example of one also. And notice how few giant cells are here. There are hardly any giant cells. There's some here that are small, but this is getting very epithelioid looking, very plump nuclei. These can be very mitotically active and they can have necrosis. So it would make you think of look, there's a mite. There's another mite. There's two in this field. They can have several mitotic figures. They can be very epithelioid looking, but yet they have, giant cells, etc. This is obviously in the hand or palm. There's an acral site. This is a giant cell tumor of tendon sheath. In contrast, this is another tumor. Same kind of site. What are those? Those are giant cells. Very epithelioid, mononuclear cells, the remainder. Not especially atypical, a little enlarged. This is an epithelioid sarcoma. I have seen several. A couple of them have been mine. Some of them have not been mine. And when they've been shown to me, they have been shown to me as anything but a sarcoma. And these can be really aggressive. Look, they have that same collagenous background that you see with giant cell tumor of tendon sheath. They have that same mononuclear predominance. Here, this is very sclerotic in fiber. This isn't necrotic. This is sclerotic. But then the key with these is that they're keratin positive. You should see a little more atypia. And then a lot of times, in even the giant cell tumor tendon sheath looking epithelioid sarcoma, you can find areas where they get more cellular and more disruptive and then have kind of a rhabdoid look. That's kind of characteristic of these SMARCB1 deficient. So this would be INI negative, keratin positive. The problem with epithelioid sarcomas is they're usually younger at like adolescents, young men. So you don't think it's going to be a malignancy, but then they can mimic a lot of things. They can not only mimic a giant cell tumor of tendon sheath, they can mimic an angiosarcoma. And the problem is they're CD34 positive and they're often ERG positive. So when you see this, like the way it's kind of making these vascular spaces, this can look like an angiosarcoma. And if you stain it thinking it's with vascular markers, you're going to call it positive because they're often stained with these vascular markers. Now, the other thing with these epithelioid sarcomas is they're one of the sarcomas that can go to lymph nodes. So you'll often see lymphovascular invasion. Now, this one is not a diagnostic dilemma as far as calling it malignant. It's about what kind of malignancy. And again, look at these giant cells. It looks like a giant cell tumor of tendon sheath in a lot of areas. This can really trick you. You don't really think about epithelioid sarcoma having giant cells, but it really can have a lot of them. And depending on where it's sampled, you may not even be thinking about it because the vast majority of hand lesions that you're going to see are giant cell tumor of tendon sheath in practice. So you really have to kind of be suspicious of these cases based on the epidemiology. Another thing about epithelioid sarcomas is they can cause necrosis. So they can look like infectious because they can get really close to the skin because they have this vascular pattern and they can show lymphovascular invasion. They can kind of cause ischemic damage to the skin. And so they look ulcerative. It's a young guy. You think, oh, it's some infection. He maybe got a splinter or something. And so then they do like a debridement and it looks granulomatous. Epithelioid sarcomas can look very granulomatous with central degeneration. But then, no granuloma should be this epithelioid with the cells disruptive in the middle. That would be weird. You really need to be thinking about it though, because just superficially, this has kind of a granulomatous look. So yeah, be careful of epithelioid sarcomas. Always have them in your differential in the hand. And that's the classic distal type. The proximal type, is more like perineal area, very rhabdoid looking. These often aren't as rhabdoid looking and they can mimic other things. All right, that's it. Sorry for the technical difficulties. Anybody have any questions? All right, then I guess I think the next one's in mid-June sometime. So I'll see you then.
Thank you.
All right, thanks
so much.
Thank you.
All right, bye.